Hello everyone, my name is Kashif Mukhtar and I'm a second year resident at St. Mary Mercy Hospital, Livonia. Today I'm going to present an interesting case of emphysematous gastritis. Emphysematous gastritis is a rare but fatal condition and the mortality can range from 60 to 80%. It is basically a diffuse inflammation of wall of stomach with gas-forming organisms, often leading to gastric wall necrosis. In most of the cases, the organism is not well identified. This is a case of 70-year-old female with past medical history significant for insulin-dependent type 2 diabetes mellitus, hypertension, hyperlipidemia, and obesity. Patient presented with acute onset of left upper quadrant pain, constipation, nausea, and vomiting. The patient's pain was sharp and non-radiating, and it was 8 by 10 on pain scale. Examination revealed sick-looking lady who was older than her stated age. She also had tachycardia and decreased breathing sounds bilaterally. Abdominal examination revealed mild tenderness in the left upper quadrant and bowel sounds were heard in all quadrants. In labs, she had elevated creatinine and white cell count. Her troponins were negative, but she had an elevated lactate of 3.4. Initially, a chest X-ray was done, which did not reveal any acute pathology. There was no pneumonia or pneumothorax. CT angiogram of the chest was done, which revealed bilateral segmental and subsegmental pulmonary emboli. Patient's abdominal pain was thought to be related to pulmonary emboli, and patient also had history of diabetes mellitus, and her symptoms of constipation, nausea, and vomiting were thought to be due to gastroparesis. Due to pulmonary embolism, patient was started on intravenous heparin and was given bowel rest and conservative treatment. 2 days later, patient suddenly developed altered mental status and hypoxia. Patient also had worsening of the abdominal pain and was visibly becoming more and more toxic. Patient's, patient's creatinine and her lactate also started to elevate. Patient was admitted to intensive care unit for hypoxic respiratory failure requiring intubation. Repeat CT angiogram of the chest was done, but it did not reveal any new pulmonary process. Instead, it showed a markedly dilated stomach. There was also gas within the stomach wall, concerning for emphysematous gastritis. Patient also started to have bloody orogastric tube output. Eventually, patient underwent EGD, which showed necrosis of the bowel wall. Image on the right side reveals a sagittal plane image of the CT scan. It shows that there is gas inside the wall of the stomach. Image on the left side is basically a coronal section, which also shows a gas that can be seen in the wall of the stomach. Images from the endoscopy reveal dark black colored mucosa depicting necrosis and a big blood clot. It was thought that the aspiration of blood from gastric tract had led to acute respiratory failure. Patient was conservatively treated without any surgical intervention. She was successfully extubated a few days later when her mentation improved but still remained poor. She was later transferred to long-term acute care facility due to her poor prognosis. Our patient had several predisposing factors including obesity, lung disease, and gastric distension. Patient also had a typical presentation with acute worsening of mental status changes, which is not uncommon, and it is thought to be arised because of systematic inflammatory response. Hence, our patient had high lactate and increasingly worsening kidney function. Patient's symptoms were acute and she required intensive care. In conclusion, it is a rare and fatal disorder. Physicians should suspect emphysematous gastritis in patients who present acutely with abdominal pain and CT images reveal gas in the bowel wall. It is also important to recognize this condition early as it can be highly fatal. Treatment is either conservative or surgical resection of the necrosed stomach. That was all. Thank you.